And I'd like to begin by giving the land acknowledgement. We wish to acknowledge the land on which 3CTN operates. 3CTN's work takes place on traditional Indigenous territories across the province we now call Ontario, and we are thankful to the Indigenous peoples who have cared for these territories since time immemorial. We acknowledge that Toronto, where the 3CTN office is located, has for thousands of years been the traditional land of the Mississauga of the Credit, the Anishinaabeg, the Haudenosaunee, and the Wendat peoples. Today, we respect and honor the presence of the many diverse First Nations, Inuit, and Métis people who make it their home. We also acknowledge that as we are meeting virtually, many others may be on different territories, so please take the time to reflect on and honor the Indigenous communities of your territories. I'm thrilled to introduce today's facilitator, Suzanne Bays, who is an active patient advocate in Canada and a member of the Patient Representatives Advisory Subcommittee for 3CTN. Suzanne.
Thanks, Alicia. Good morning and good afternoon, everyone, depending on where you are joining us from across the country. By way of introduction, I spent over 30 years in both the management consulting and technology sectors, helping clients implement change through the introduction of large-scale IT solutions. In 2005, my husband was diagnosed with early onset metastatic colon, lung, and liver cancer. But thanks to research and more specifically clinical trials, we enjoyed 2.5 years together, living the best life he could under the circumstances. So research is extremely important to me. I have devoted over a decade to helping advance the research agenda and helping people with advanced cancer get the services they so deserve. I'm thrilled to have the privilege of serving as the facilitator for the Winter impACCT virtual rounds. 3CTN continues to host these virtual rounds to support the opening of additional sites for selected portfolio trials and to increase trial awareness across the network. impACCT virtual rounds are held quarterly, and investigators are encouraged to consider bringing forward their portfolio trial for inclusion in upcoming sessions. You can submit your questions at any time today. Questions can be submitted live on Slido through the webinar session with the event code #winter. Attendees will also have an opportunity to ask questions live using the raise hand feature in Zoom or in Zoom chat. If there are any outstanding questions after the session, we will reach out to the presenters and share those answers with you. We have 3 amazing speakers today, so we are extending the session until 1:15 Eastern. Please try and stay until the end if possible. So without further ado, it is my honor to introduce our first amazing speaker, Dr. Chris Yu. Dr. Yu will be presenting on an exciting clinical trial entitled StopMed CTRCD, a multi-center, non-inferiority, randomized control trial of stopping cardiac medications in patients with normalized cancer therapy-related cardiac dysfunction. Dr. Yu is a cardiologist with expertise in cardio-oncology at Toronto General Hospital, UHN, where he also is an assistant professor at the University of Toronto. His research focus includes cardiotoxicity risk prediction in cancer patients receiving cancer therapy, as well as reducing adverse cardiac outcomes in cancer survivors. Please join me in welcoming Dr. Yu to share his insights on this exciting clinical trial. Over to you, Dr. Yu.
Thank you, Susanna, for that lovely introduction. I'll just share my screen. So thank you, Susanna, for giving us the opportunity to talk about our study called the StopMed CTRCD study. And thank you for reading out the word jumble underneath it. But this is below our study partners to date, and also some of our study sponsors who are grateful for helping fund our study. So I'm just going to start off by just trying to explain what CTRCD. It stands for Cancer Therapy Related Cardiac Dysfunction. And essentially in patients who receive potentially cardiotoxic therapy, in particularly anthracyclines or HER2 targeted therapies, cardiac surveillance is really important, as we know that there is a risk of CTRCD occurring in as high as 20 to 30% of patients. So the images that I've got on the screen, I hope they're not too jittery for you, but essentially it's a patient on the left hand, it's the same patient in the left and the right hand side, and it's a patient on the left hand side pre-cancer therapy where they had a normal heart function, but then during their anthracycline therapy and subsequent HER2 targeted therapy, they experienced a decline in their heart function. So for these patients, what we do is we start them on heart failure directed therapy, which is often an ACE inhibitor or a beta blocker. And if the ACE inhibitor is not tolerated, sometimes it can be an angiotensin receptor blocker. And in these patients, they can often expect to have some improvement in their heart function. And the issue that a lot of patients come to us in our clinic afterwards, when they finish their cancer therapy, is that they feel well, they have no symptoms, and they know that the cancer therapy caused their heart dysfunction, and they're not getting any more of that cardiotoxic therapy. And they just don't like taking medications because they're associated with cost, but more importantly, just side effects such as low blood pressure, which causes dizziness, fatigue, and other complications. And so in terms of where we are in the cardio-oncology space, the management of CTRCD is really guided by the latest guidelines in 2022, which were the first guidelines. And in the flow sheet here on the diagram on the left-hand side, essentially this guidelines suggest that in those that had only mild or moderate CTRCD with full recovery, you could consider stopping their heart failure medications. And that's shown here in the yellow box. But the evidence behind this was really expert opinion with no concrete evidence to support that recommendation. And that's really what this trial is about. It's trying to provide an evidence base for that recommendation. So here's some of the brief work we've done before I focus on the trial. We looked at 20 patients at Toronto General who essentially had cardiotoxicity. They were HER2 positive breast cancer patients who got anthracyclines and trastuzumab. And we had 10 patients who wanted to stop their medications, predominantly due to fatigue and just not wanting to take any medications anymore. And on the graph on the right-hand side, we tracked their heart function. So we tracked it from pre-cancer therapy to the time of CTRCD, to the time at the end of their cancer therapy where it improved, and at that time, what we call the index date. And really, we want to focus on this period here, where 10 patients continued, 10 patients stopped, and over 2.5 years, the heart function between the two groups remained unchanged. And this pilot data was really important in helping us achieve CIHR funding for this study. So the StopMed CTRCD trial, it's an international open label randomized controlled trial with blinded determination of outcomes. And we're randomizing patients to continuing their heart failure medications or stopping it. The composite primary outcome is the proportion of those that develop by 1 year follow-up the decline in their heart function below 50% by cardiac MR, or those who develop new heart failure signs and symptoms requiring heart failure therapy. So the study team to date is led by Dr. Tavinder Nathan, who's also on the call. And here are some of the list of our co-investigators across the country and our administrative team here at UHN. And in terms of the Canadian sites, we have 6 Canadian sites involved so far. So we have input from Edmonton, Winnipeg, and within Ontario, Hamilton, Ontario, and Ottawa. But we're hoping to expand within Canada this study. And so really, hopefully, we would interest you enough that you'd be able to help join our study in the near future. In terms of global sites, we also have sites in the US, the UK, and Australia. So these patients would probably be known to your oncologists, and they'll be seen really more infrequently, really in this, the post-cancer treatment therapy phase and more just in the surveillance monitoring. And I suppose your oncologists may remember those who have patients of theirs who had cardiotoxicity, who needed medication stop to treat it. So in terms of the inclusion criteria, really it's adult patients greater than or equal to the age of 18 who had cancer therapy completed more than 6 months ago. So they would have had either anthracyclines and or HER2 targeted therapies. They would have had asymptomatic moderate CTRCD by the ESC criteria, and they're currently on greater than or 1 or more heart failure medications for their CTRCD, and they have a normal function assessed by echocardiogram, a normal NT-proBNP, and are asymptomatic. They would have an MRI for the final inclusion criteria, but I'll talk a bit about that in a short while. In terms of the key exclusion criteria, really it's for patients who need to continue their heart failure medications, those who had severe cardiotoxicity, or those who have metastatic disease or life expectancy of less than a year. So this is the study flow chart. We'll just go from top to bottom to explain how the study works and just the workflow. So essentially, a potential patient's identified who has a history of cardiotoxicity with normalized left ventricular ejection fraction. They'd be invited for a screening visit for informed consent. We'd check essentially that they have a normal NT-proBNP and normal heart function by transthoracic echocardiography. And then they'll be invited back for a baseline visit. And at the baseline visit, that's where they will have a cardiac MRI, just because that's the tool that we're measuring the primary outcome with, and it's the gold standard for measuring volumes. And essentially, if their heart function in their left ventricular ejection fraction is less than 55%, they get excluded at that time point. But if it's greater than 55%, they get randomized. We're hoping to recruit 335 participants in a 2-to-1 manner. So for every 3 patients, 2 will go in the stop group, 1 will go in the continue group. And the reason for that is really just because we know in the continuation arm, we don't anticipate anything to happen. And it's really the stop group that we're interested in. So when the patients are randomized, they all get given a blood pressure machine and a blood pressure diary for safety. We then follow up with them in 6 to 8 weeks to just check on their blood pressure readings and their vital signs to make sure no one's developed any untoward hypertension from stopping their medications. And they come back again in 6 months for safety, where we check their heart function. They then come back at 9 months for safety, just to check their vital signs and symptoms. And then at 1 year, they have the primary outcome visit, which is the cardiac MRI, as well as a transthoracic echocardiogram to assess their heart function. We do intend to continue follow-up for 3 and 5 years, and that's really just buy-in from the CIHR grant application, that people felt that measuring people to 1 year is insufficient, and we should be measuring patients for the medium term to assess the true safety of stopping medications. So in terms of sites, the key resources that we want from sites is really if they have access to echocardiography, that's important, as well as cardiac MRI. But I want to stress that in terms of interpretation of these images, we can do that to help in terms of resources, or if it helps save cost, we're happy to, at UHN, for it to all be centrally measured by ourselves. So I'm just going to quickly just show you some of the study procedures in terms of how it works. So this is an example of how we would stop someone on ramipril and bisoprolol, as shown on the right-hand side. Essentially, they get their medications reduced by 50% at a time every 7 days. So in this case, it's ramipril first, goes from 10 to 5 to 2.5. And then at 25% of the maximal dose, it goes to stop as the next step. And when they stop the ramipril, they can start reducing their bisoprolol to cessation. On the right-hand side of the screen is a patient diary that we give to the patients. All patients will, as I said, will get a blood pressure machine, and we've encouraged them to check it a few times a week. And we've got Canadian guidelines in terms of when to restart antihypertensive therapy, as shown over here. For safety, we've also got some pre-specified criteria for restarting heart failure medications, which are very similar to the primary outcome. And we've also experienced from our recruitment to date reasons for why patients may need to restart their heart failure medications. And predominantly for us, it's really been the blood pressure management. Some patients have developed hypertension as a result of stopping their medications, and we've just restarted them on alternative antihypertensive therapy. So this is our data safety monitoring board, which has a cardiologist and an oncologist on the team. And they've helped us really guide some of the safety parts of this study. But I'm just going to lastly just show you the study timeline for the study. And really, we started out in 23 with ethics applications and grant applications over here. And in 24, we were successful in obtaining CIHR funding. And as well, we also started recruitment at UHN in March of last year. And to date, we've recruited 18 patients at UHN. We've also started at a couple of international sites in the US and Australia and started recruitment there. And we're hoping to start recruitment within the other Canadian sites in before the second half of this year. So we're in 2025 currently, and really for us is really just trying to advertise the trial to see if anyone would be interested in helping us try and reach that target of 335. And if there's anything we can do to help bring you on board as well, we'd be happy to talk offline about that. So thank you for your time. I'm just going to stop there for any questions.
So thank you so much, Dr. Yu. That was just terrific. Just before everybody starts to enter their questions into Slido or into the Zoom chat, I've got one question just to kick us off. So
Sure.
how do doctors respond to cancer survivors frequently asking if they can safely stop their heart failure medications once their heart function has returned to normal? Do they wait for the study to complete, or is it up to the doctor's judgment? And does the patient have the right to make such a request?
Yeah, that's a really great question, Susanna. So I think it's a frequent question, not just asked in our cardio-oncology clinic here in Toronto, but from speaking to our colleagues globally, it's a frequently question that patients ask themselves. And I think they're entitled to ask that question because, medications are associated with all sorts of issues, like, as I mentioned, cost and more concerningly, adverse side effects. So currently, it's really case by case shared decision making in terms of what we do currently with the guidelines that kind of help support us. But I think really, like, if we really want to give confidence to physicians to stop medications, then this trial is the answer to that question. So we're in 25, so I'm hoping by 27, 28 that we will be able to answer the question with the results of this study, and hopefully also influence guidelines and give at least randomized control trial evidence to the guidelines to support potentially stopping. And if this trial shows it's not safe to stop, then also it's a benefit to patients as well, because then we can also say to the patients it's not safe to stop.
So here are some of the questions that have come in. So usually, how long does it take for a patient's heart to return to normal after the cancer therapy?
Yeah, so again, so it's a variable from patient to patient, but generally I'd say it's between 6 to 12 months. Sometimes we do see after starting heart failure medications, the patient's heart function does recover much sooner than that.
Okay. And is there any data right now to estimate potential cost savings based on this study?
So there's no data currently in the literature, but that's one of the things we're looking at in this trial. So I didn't talk about it in too much detail, but we are planning to do a cost effectiveness analysis, and that's being run by the University of Toronto team by Dr. Valerie Rack. And so we anticipate that if the trial shows it's safe, that we may potentially show that there is cost savings, and that would be fantastic if it does, because the cost savings we see in our mind would be not only just the cost of not having medications, but reducing the burden on very busy clinic times. And so it frees up time for patients who need to be seen more urgently to be seen in our clinic. So that is something that we're looking at.
Great. And the last question in the chat right now, and this is something near and dear to my heart, because as a patient, the coordination of care is often a challenge. So as this is related to cardiology, how do you work with the Cancer Center Clinical Trial Unit for this transition of care?
Yeah, so often these patients would be seen in our clinic currently. So they would have been referred by the oncologist during their cancer therapy and when they developed CTRCD. And so their patients have a relationship with us and we have a relationship with the oncologist. So it's kind of a tight network. So I suppose there is no per se transition of care in this scenario, but in terms of for this trial, if oncologists want to help us and cancer center clinical trials want to help us, then we would be able to help bridge some of that transition support there.
Okay, and then in the chat, there's one question that's come in. How many more sites are you looking for? The slide went by quickly and I probably missed it.
Yeah, so we're on 10 sites currently, but we're hoping to get to 20. And I think realistically with 20 sites recruiting between 10 and 15 patients, that will help us achieve our target.
Excellent, excellent. So I don't see any other questions unless I'm missing one of the channels. So Dr.
Suzanne, there's a question on the screen, sorry.
Oh, okay. Could this clinical trial be eligible for CRAFT? through 3CTN is some sites do not have cardiac MRI available. So those are those sites where you're regionally distributing the clinical trials.
Sure. I'm actually not sure what CRAFT is,
So,
but thank you for
sorry,
raising
can
it.
I maybe just clarify what is CRAFT? CRAFT it stands for Canadian Remote Access Framework. So it's whether the primary site and secondary site can work. So just for Dr. Yu.
Sure.
It's really based too on getting some equitable, clinical trials up in areas beyond sort of the big cities. So very important work.
Oh, that sounds fantastic. Yeah, look, we would be open to looking into that. So thank you for raising that question, and that's something we will look into.
Excellent. I know we have some 3CTN people on, so I think that will be something for them to follow up with you on. That's great.
Thank you.
Dr. Yu, thank you so much for this really, really interesting trial. And I think, everybody's learned a lot today from this, and hopefully with some of the audience members that you've got some interest in opening up the trial to some more sites, ideally in remote areas too. So thank you so much.
Thank you.
Okay, I think we're on to speaker number 2 now. So it's my honor to introduce our second distinguished speaker, Dr. Ian Poon. Dr. Poon will be presenting on an exciting clinical trial entitled a Phase 3 Randomized Control Trial comparing palliative stereotactic body radiotherapy versus palliative standard radiotherapy in patients with advanced head and neck cancer. Dr. Poon is a radiation oncologist at the Odette Cancer Center, an affiliate scientist at the Sunnybrook Research Institute, and an assistant professor at the University of Toronto. Dr. Poon's research interests include radiation oncology, head and neck cancer, lung cancer, and stereotactic body radiation therapy. Please join me in welcoming Dr. Poon to share his insights on this exciting clinical trial. Over to you, Dr. Poon, who can share your screen.
All right, thanks. Here, you can see and hear me, I think.
Perfect.
Hang on a second here. No. Okay. Let me. Okay. So thank you for the invitation. As you heard, I'm a radiation oncologist at Sunnybrook Odette Cancer Center. I'd just like to quickly acknowledge all the people that have been involved in this trial. Irene Karam is a radiation oncologist at Sunnybrook 2. Huda Bahig is one of the listed trial committee members here from McGill. Gillian Size from Princess Margaret. Adam Mutzers from Western Ontario, London, Ontario. Murali Rajaranam is from Dalhousie, and Brock Denebam is from Edmonton. I'd also like to just acknowledge Wendy Peruklar, who is the senior investigator at the Canadian Cancer Clinical Trials Group. So this is just a brief summary of the treatment options for the advanced head and neck cancer patient. And really the successes and the focus of major cooperative head and neck cancer trials have been in this upper region here for the patient that's fit and younger, where patients are exposed to more intense forms of treatment to improve their chances of curing their cancer and better local control, which is the premium for in head and neck cancer. So they often are exposed to surgery, very extensive surgery, and/or high-dose radiation and chemotherapy. And yes, they do achieve higher rates of local control with this more intense treatment, but it also tends to be quite highly toxic, and the recovery can be very prolonged. So in patients that can't undergo that kind of intense treatment, they're often relegated not to surgery, because that's often the most intensive treatment, and chemotherapy often is quite dangerous too for the unfit patient. So they're often relegated to radiation, and the more unfit they are, they tend to receive smaller and smaller amounts of radiation. And then as a consequence, in a general way, that often leads to less probability of control and more symptoms because they can't handle the toxicity of the treatment. The problem, though, is that head and neck cancer is a disease of the aging, and it's estimated by 2050 that there will be a tripling of Canadians over the age of 85 compared to a 2021 census of that was 861,000 people in Canada. And these elderly and unfit head and neck cancer patients have been routinely excluded from these cooperative trials. And so that's what makes HN13 a bit more unique, because the focus is on the frail head and neck cancer patient that's unable to tolerate curative treatments. And the trial is unique partly because the attempt is not only to attempt to palliate symptoms, but actually improve cancer control. And that's through the use of stereotactic body radiation. So I think this is a general audience. I'll just try to summarize this in a more general way, but SBRT is really can be summarized in the diagram on the left there, whereas conventional radiation is a series of daily treatments, usually 2 gray per day over 5 days a week for 7 weeks. Sorry. And so it's spanned that 7 weeks is really the maximum amount of radiation you receive for head and neck cancer. SBRT is basically, in a simple way, using a bigger bullet with each treatment. It's only delivered over 5 treatments twice a week, but each treatment, which is a bigger bullet, so it's 9 gray, which is almost a week's worth of radiation delivered in a single treatment. And the only reason that can be safe is because over the last 30, 40 years, there's been quite a lot of technology that's been introduced to radiation oncology that allows us to focus and sculpt the radiation to be more precise in how we define the tumor, as you can see there on the right. So there have been a number of retrospective studies that mostly have been published out of Sunnybrook in head and neck SBRT, and they've shown promise that there seems to be improved higher rates of local control. It seems to be tolerable, but again, it's limited because of its retrospective and a single institution. So just to help frame things, will show you a couple examples of a few patients that have been treated at Sunnybrook. This is an 88-year-old lady, poor performance status. ECOG3 means that she has limited self-care abilities, and she spends more than 50% of her time in a bed or wheelchair or chair. She presented with a very large tumor of the floor of mouth. You can see it there on the bottom left. These are her teeth that are floating in this tumor in the floor of mouth. And then she has a very advanced cancer growing actually from the lymph node that's almost breaching skin, as you can see there. So she was treated with SBRT, and she remains well many months later. On the top, there's an 86-year-old lady, again, not very well, unable to receive curative intent treatment, which would have been, in her case, very, very extensive surgery because it involved the parotid gland as well, and followed by some form of adjuvant treatment. So she again received SBRT and remains well many months later. On the bottom row is a 92-year-old with an advanced palate cancer, hard palate cancer involving the bone, breaching the bone, that was treated with SBRT, and she is also well many months later. So that sort of promising data has led us to what we've called the on-task study, HN13, which is optimizing head and neck cancer and head and neck tumor and symptom control in patients unable to tolerate curative radiation, comparing SBRT to standard radiation. And we're comparing overall survival as the primary objective in these participants. There are secondary objectives, including the typical standard cancer statistics of progression-free survival and local regional failure. We're also interested in toxicities, both acute and long-term, because that's obviously pretty critical. Patient-reported outcomes will also be really important too. There are some tertiary objectives that are comparing overall survival by ethnic or cultural origin, and also to determine if there are any differences in overall survival associated with social determinants of health. So there's a summary of the trial. Patients have to have biopsy-proven mucosal squamous cell carcinomas of the head and neck that are unable to tolerate standard curative treatment. They're randomized 2-to-1 to the experimental arm, the SBRT arm on the bottom. The standard arm actually is a dealer's choice, and this is a commonly used standard regimens across Canada. 25 gray and 5 fractions over a week's time. That's 5 gray per day over a week's time is a standard treatment in Quebec, and they are quite important contributors to CCTG. But the rest of the country is commonly using this other regimen that we call 0721. So it's delivered, radiation is delivered on day 0, day 7, and day 21. That's why it's called that. Patients will be stratified by TNM stage. So the most advanced cancers, the T4 and the N3 cancers, will be stratified in one group, one arm versus the other, and they'll also be stratified by performance status. So as I mentioned, these are biopsy-proven squamous cell carcinomas only from the head and neck. They wouldn't be allowed to have any prior systemic therapy, including immunotherapy or prior radiation. And most importantly, as I've mentioned a few different times, that they have to be considered unfit for curative intent radiation as determined by the treating doctors. We've incorporated a frailty index, which is the first time that CCTG has actually used a frailty index. And this is a frailty index called the Geriatric 8 screening tool that's been quite widely used across the world, but used for the first time at CCTG. The power statistics are looking at overall survival, as I mentioned. So based on retrospective evidence, the experimental arm, the estimated 1-year survival is 40.3%, with a standard of care estimated to be about 22%, and using standard power calculations and a 15% dropout ratio, we get a hazard ratio of 0.6, and with a randomization ratio of 2-to-1 to the experimental arm, that sample size calculation comes out to 196 patients. So the trial accrual is we hope to accrue 49 patients over 4 years. Through our initial application to CIHR, we have 14 centers across Canada that have agreed to participate. And we hope that the engagement will be strengthened by both patients and physicians, partly because head and neck SBRT, it is a novel technique and most of the experience has been at Sunnybrook, but there is some experience in McMaster and Western and McGill, but for most of the other centers, head and neck SBRT is new to them. The SBRT, I should say, though, is quite commonly used across different kinds of cancer, lung cancer, liver cancer, spine cancer, but to head and neck is actually a bit more unique. In most cancer centers, although they have the equipment, they actually don't have the experience with this. So we are hoping that this trial will actually act as a kind of a springboard for departments to get more comfortable and to understand how to best deliver this kind of treatment. There are patient-reported outcomes, and so there is definitely a patient-focused to this trial. And the protocol design is meant to minimize patient burden by allowing for telehealth, for example. There aren't any other competing trials for this particular type of patient in head and neck cancer, so that's obviously helpful. And I think among physicians and patients, I think it's considered this trial is trying to meet an unmet need prior to this for the unfit and unhealthy patients with advanced head and neck cancer. There aren't a lot of great options. Also, this trial has been earmarked by CCTG for their DEIIA initiatives that allows them to provide additional funding for patients for reimbursement for standard things like transportation. But there is also standard funding that is pretty generous, actually, for a fairly short follow-up kind of trial. So where are we at right now? Well, we did achieve clinical trials funding through our CHR in the competition, in the spring competition in 2023. It was activated centrally through a CCTG in the fall of 2024, and the activation across Canada is ongoing, and we are expecting accrual to start in April 2025. Thanks very much.
Thank you. Oops. Thank you so much, Dr. Poon. That was great. I think, as we said before, if you've got questions, you can insert them into Slido using #winter. And we've got a few questions here. So this might have been covered during your presentation, but I think it bears sort of just reaffirming this a bit. So there have been several head and neck trials funded by CCTG, HN.6, 9, and 10. So
Right.
how is this a bit different? I know you mentioned, sort of an aging population, but I noticed that, as part of the criteria for the study, you didn't have to be a certain age. So, maybe you can just walk us through that.
Right. So I think that is an important thing to highlight. And I'm just trying to, do I need to unshare my screen just in case I don't want to foul up things for the future?
We can see you, and,
Okay.
and we can't see
Anyways,
your slides, so it's all good.
so basically, I think you're asking, well, how is this different from the other trials? I mean, HN6 and HN9, they were in a completely different patient group. So those are patients that were generally younger and fitter, and the questions were related to how can we cure your cancer in a more standard way with more intense treatment. And this patient group actually is a much elderly, more frail group. And so you're right, we didn't set a particular age for patients, because you can have a very frail 65-year-old patient too that actually is unable to tolerate curative treatment. So it is actually using the multidisciplinary team, the treating oncologists, as a guide to define who they feel is not fit to receive curative treatment, and from there, then they decide whether or not that this trial is a good option for them.
Yeah, that's great. One of the other questions that I was thinking about when you were doing your presentation, that this qualifies for sort of additional DEI funding, and a lot of the trials have difficulty with diversity and getting the groups involved in trials. Is there any kind of specific reach out to some specific groups to try and get the numbers up that you need?
Well, I think that's a good question. I think that there are, this kind of cancer is still a very uncommon, head and neck cancer in general is a fairly uncommon cancer. And so, we talked about, there is an outreach that needs to take place, but in fact, it really filters from, specialists to come to the cancer center. So even if you were to try to outreach to, sort of a general audience, it would just apply to too few of a group of people to really be very effective. I think we think that this trial is more likely to actually be more diverse and actually allow for other groups that previously weren't involved in clinical trials, is because this kind of trial actually removes some of the barriers that patients have to in getting radiation, for example. Because if as I showed you, the standard treatment is many days of radiation, 5 days a week for 7 weeks. But this trial is actually looking at a very short course of radiation, so 5 days of radiation. So it means that patients who actually are unwilling or unable to go through to actually come to the cancer center actually are more likely to do that.
Yeah. Yeah, I mean, it probably is pretty rough for those 5 days, but at least you're not having to come back and forth, particularly if there's, long travel involved. And I think, from a patient perspective, that would be very, very useful.
And so I should say, and last thing I briefly went over it is that, the CCTG, the Canadian Cancer Trials Group, does recognize that as a potential barrier, and that's why this has been earmarked for some of their DEIIA initiatives. So in fact, they have earmarked additional funding to help with transportation costs, for example.
Yeah, that's super. Another question has come in. What is required for credentials for sites? Sometimes this can take extra time, and will there be central reviews of first patient cases?
Right, there is definitely credentialing. Not so much, there is credentialing for sites, but as I briefly mentioned, I mean, SBRT is actually very commonly used in the majority of even community centers across Canada. And so the actual technical requirement is actually fairly minimal. There's a facility survey that people will need to fill out, but I don't think I don't think any center would have a very difficult time in achieving those standards, or that if that's a problem. There is what the credentialing that actually is more involved actually is actually that each oncologist, each radiation oncologist that wants to accrue to this patient will actually have to undergo a credentialing, a case-based credentialing system. And we have funding to actually have an oversight from what we call QORC, which is an American infrastructure that actually allows us to to control that. And the review, in each case, actually, not just the first case, but actually every case actually is going to be reviewed centrally before patients actually undergo treatment. And I actually don't think it is actually, the oncologist will see that as a burden. I think the oncologist will actually value that every case of theirs is being reviewed and overseen by more experienced people in this particular type of radiation.
That's great. I don't know if we have any other questions, but as one of those people that'll probably hit that cohort by 2050, I'm very happy to hear about research for elderly people. I'm hoping I make it that far. So anyway, thank you, Dr. Poon, for your excellent presentation. I really enjoyed it, and I learned a lot today too. So I really, really appreciate that. I think if we don't have, I'm just going to check one more. No, I think we're good, and we'll go on to our third speaker. So it is my honor to introduce our third and final distinguished speaker, Dr. Bernie Eigl. Today, Dr. Eigl will be presenting on an exciting clinical trial entitled Modern, an integrated phase 2/3 and phase 3 trial of MRD-based optimization of adjuvant therapy in urothelial cancer. Dr. Eigl is a staff medical oncologist at BC Cancer Vancouver Centre and a clinical associate professor in the Division of Medical Oncology at the University of British Columbia, my alma mater. Dr. Eigl's research interests center on genitourinary oncology clinical trials and biomarker research with a special focus in bladder cancer. Please join me in welcoming Dr. Eigl to share his insights on this exciting clinical trial.
Okay, am I unmuted now? Oops, can you hear me now? Sorry.
Yes, we can, and we can
And
see
you can see my screen.
Yeah,
Yay,
we can
thank
see
you.
you. Thank you.
Okay, thank you so much for the invitation to speak today. As mentioned, I'll be talking about the DLC6 study, or Modern, and I'll just get going with that. So the Modern study is a international collaboration. Dr. Galsky and the Alliance group started this study, and CCTG is joining the study, for which I'm the Canadian chair. You can see here the other parties involved, and we have 20 Canadian sites at the moment committed to the study, but always happy to look for more. In terms of background, bladder cancer is the 5th most common cancer in Canada. And for patients who have muscle invasive disease, this is a curable disease, but only about 50% of patients with prior treatment achieve cure, and effectively the rest progress to disease which have poor prognosis. The standard treatment for muscle-invasive bladder cancer is neoadjuvant chemotherapy, followed by definitive local therapy, usually surgery, cystectomy, or tri-modality therapy with chemoradiation. And for patients who still have cystectomy and who have high-risk disease after cystectomy, the standard treatment at the moment is to give adjuvant immunotherapy with nivolumab. And you can see here the progression-free survival curve, or disease-free survival curve for nivolumab compared to placebo from the CheckMate 274 study. So this and survival data has now read out. This is a study that improves survival. Treatment that improves survival, and so nivolumab is a standard of care given as a 2-weekly immunotherapy regimen for a year after cystectomy in those patients. The reality, though, when we look at the survival curve, is that there's a proportion of patients that are already cured by their chemotherapy and surgery. And really, there is no systemic therapy that can improve the outcome for these patients. Again, because in the placebo arm, we can see that they have already achieved a long-term survival from what they have previously received. The converse of that is there's a major need to improve the outcomes for patients in the upper part of this curve, where nivolumab did not improve their chance of cure, and these patients relapse. And so really the benefit is that small margin in between the two curves that do derive some benefit from immunotherapy. Obviously, we would love to be able to identify those patients who fall into those other two groups so we could tailor therapy for them and intensify for the higher risk population and de-intensify for the patients who hopefully are already cured. And that's where this study comes in. Before I get into the study, just to provide a bit more background, a lot of my work, of course, is in circulating tumor DNA, and that's the backbone of this trial. There is a type of circulating tumor DNA test that is now performed to find what is called molecular residual disease or minimal residual disease, MRD for short. And basically, to start with, again, as background on circulating tumor DNA, you can imagine if we have cancer growing in our body, as those cells grow and some cells die, they spill DNA into the bloodstream. We now have tests where we can take a tube of blood and we can isolate the DNA in the blood and find that DNA which comes from the tumor. And so identify, sometimes depending on the test, we can identify mutations that are driving that tumor, or we can just identify the presence of tumor with these highly sensitive assays. And this slide that I'm showing here is for one of these highly sensitive assays. It's called Signatera. Is an option that's widely used in the United States, but is not a standard option in Canada at this point. But basically, the way this test works is tumor tissue is taken from the patient. So in the case of bladder cancer, from the cystectomy specimen, and mutations specific to that patient's tumor are identified, and tests are developed that are very sensitive to identify whether any of those mutations are present in the patient's blood after surgery. And on the right side, you can see here that the ideal would be that patients who are ctDNA positive will become negative with their treatment and remain so. And this test has been shown very well to predict early for patients who still have residual disease or who have relapse of disease if the DNA test becomes positive later. There's been quite a lot of work done in bladder cancer, and this slide is just to show that in a different trial looking at another immunotherapy given in the adjuvant setting, atezolizumab. This was actually a negative study, but post-hoc analyses of patients' ctDNA samples showed that on the left curve, you can see here, those patients who had a negative circulating tumor DNA had good outcomes, whether they received immunotherapy or not. And the real benefit of immunotherapy was driven in those patients who had positive ctDNA, but also had a very poor prognosis, as you can see. And the same is true on the right side for the overall survival. So the proposal, the goal of this study is to evaluate the utility of this tissue-informed ctDNA testing to identify high-risk and low-risk populations to evaluate really tailoring the approach of therapy for these populations. And as you can imagine, then this is a potentially practice-changing study. If it's positive, it will avoid treatment toxicity and high costs for a large population who may not need adjuvant therapy. Obviously, that's especially relevant in the Canadian healthcare context. And it will evaluate intensification for those patients who are likely to relapse or very likely to relapse with incurable disease. Can we intensify treatment after surgery and hopefully render more of those patients cured than with current treatments? And if positive, this would change actually the way we design future studies entirely. So the study schema is outlined here, and I'll go into more detail as we go. On the left side here, patients who are eligible for the study are those really that we would normally give adjuvant nivolumab therapy to. So high-risk patients who have either received neoadjuvant chemotherapy with cisplatin-based treatment and who still have residual muscle-invasive disease or node-positive disease, or patients who were not eligible for chemotherapy and had invasive disease or node-positive disease. And those patients would then have the tissue-informed ctDNA test designed and the testing done. And at registration, if they are ctDNA positive, they would go into cohort A at the top and be randomized to receive either the standard treatment of nivolumab for a year or nivolumab plus another treatment, relatlimab. As background, relatlimab is another immunotherapy checkpoint inhibitor. It's a checkpoint called LAG-3. This combination, nivolumab and relatlimab, has shown good promise in bladder cancer. It's already a standard treatment in melanoma, where it's been shown to be better than nivolumab alone as a combination immunotherapy. So this is really an intensification of the therapy for those high-risk patients. And the patients who at the outset are ctDNA negative would be randomized to a de-intensification schema. So half of them would receive, if they'd be randomized, to receive standard nivolumab therapy or surveillance, so no therapy, but recurrent ctDNA testing. And if their ctDNA becomes positive, they would get nivolumab treatment at that point. Explain that. So just focusing in on the two cohorts a little bit more closely, this is designed as what is called a a seamless phase 2/3 study. There will be an initial phase 2 component to really see, are we correct in the assumption that this combination is more effective than just nivolumab alone? And so 223 patients would be randomized, and at 12 weeks, if we find that the ctDNA clearance, so going from positive to negative, is greater in the combination arm, then it would proceed to phase 3 superiority design study with an overall survival endpoint. And you can see here the numbers, 223 patients for the initial study. And if we expand a cohort for a positive signal, it'll go up to 475 patients in total. And cohort B, the de-escalation cohort, is a non-inferiority study, straight phase 3 study, really looking at if this combination is not inferior. Sorry, if the surveillance approach is not inferior to giving adjuvant nivolumab. You can see the secondary endpoints here: disease-free survival, proportion who are ctDNA free at 12 weeks for cohort A, and overall survival, and the incidence of ctDNA conversion, and lead time from seeing a positive ctDNA signal to actually seeing recurrence on CT scans and radiographic imaging down the road. And other correlatives will include quality of life and cost and value of care analysis and biobanking. Excuse me. The eligibility is really very appropriate, excuse me, and very similar to what other studies in this setting have set out, like the Checkmate 274 study I alluded to at the beginning, and is the kind of study that Canadian investigators have accrued very well to in the past. There is, just to sort of digress a little bit, the landscape of treatment for muscle-invasive bladder cancer is really evolving, and there will be newer approaches. The combination of immunotherapy with chemotherapy before surgery is an emerging standard of care now that will probably become a standard of care in the coming year. And so there's already a protocol amendment submitted to the registration bodies to allow for neoadjuvant immunotherapy in these patients. And amendments will probably come as the landscape changes over time. Key eligibility is listed at the bottom here, and really is quite standard. In terms of the importance of Canada specifically, beyond what I've already mentioned, this is really a potentially practice-changing study that could improve not just outcomes, but toxicity profiles for our patients. It provides access to nivolumab. There are some jurisdictions in Canada that don't have access to nivolumab in this setting, or that have access for specific population only. It will provide access to relatlimab, which again is a treatment that has really good promise in this disease. The Signatera testing, again, is something that we don't currently have access to in Canada, and so the study will provide experience for us with that testing as well. And as I mentioned, really the treatment avoidance and resource savings for large cohort of patients who don't need further therapy after their surgery. And again, our B community is a very strong community in this sort of setting.
Okay, thank you so much, Dr. Eigl. I think we have a few questions in the chat. So here's the first one. Timing of the ctDNA testing adds complexity to the trial. What would you recommend the site manager do to work with the surgical team to get sort of this done in a timely fashion?
Yeah, that's a great point. So, I mean, from our experience in working with these perioperative and adjuvant studies in the past, is you really need to identify the patients early, ideally. Luckily, neoadjuvant chemotherapy, which is a standard of care, well established now, is increasingly becoming utilized in Canada. And so hopefully medical oncologists are involved in the care of these patients before surgery, such that they can present the trial opportunity to the patients before they have their cystectomy, and then really working with the surgical team to say, this is a study we're looking at, and figuring out some of the kinks, if you like, at the local site in terms of making sure the tissue can be accessed and sent for the creation of the ctDNA test. And the timelines are really quite reasonable. I think that we should be able to achieve this, but again, we'll see how it goes.
Okay. Next question. How effective is the ctDNA testing? And is this test available to the patient if they don't join the trial, if patients ask this to their doctor?
So the Signatera test is a commercial test right now, and not available in a funded way in Canada. Patients could request the testing and have it done. The cost of testing, I don't know exactly what it is, but information can be found. Like I said, it is something that has very good data in some specific disease sites like colon cancer and bladder cancer. And hopefully a study like this will help us show that it's a cost-effective thing to do to avoid expensive therapies down the road, so that it will become standard for all patients.
Yeah, and if the patients have to pay for it, it excludes some people just because of cost, and that's not a good way to have it. But it does give benefits to people joining your trial. So there you go.
And to be clear, it is not a standard of care test, even in the States, although it's widely used. We're not at the point to say this is something that will predict whether your cancer is going to come back, or will give lead time that would make a difference clinically. It's these kind of studies we need to really show that. So I'm not saying to people go out and get the testing done, because I can't say that it's definitely going to improve any outcomes. Yeah.
I don't see any other questions in Slido. Has anybody else got any? Don't know. It seems to be that's the end of the question. So I just have a quick wrap up for everyone. So as today's virtual rounds come to an end, I want to thank Doctors Chris Yu, Ian Poon, and Bernie Eigl for sharing your knowledge and expertise with us today. We also want to extend our gratitude to all the participants for attending today's session and making it a success. We hope that you found the presentations both informative and thought-provoking. Please note that certificates of attendance will be provided to those who have registered and attended the session. These certificates will be sent via email in the coming days. For those who missed the session or wish to revisit the presentations, we will be sharing the recordings in the coming weeks. Please keep an eye out for an email from us with the link to the recording. Thank you once again for participating in the Winter 2025 virtual round session. We hope to see you all at the next session, and thank you very much.
Thank you, Suzanne, our patient representative, for your wonderful facilitation of today's rounds. And thank you again to the presenters, as well as everyone who joined to participate. Please email us at info@3ctn.ca if you have further questions about the trials presented.
Thank you.